All right, everyone. I am your MC for the night, along with Dr. Saibal Carr, and we've got a great faculty, so start getting your food, start heading to sitting down. We've got so much data to grasp and so little time. So what we're going to do is talk about both MitraClip and TriClip, and you'd think we had COAP, we have all the data that we need, right? But it turns out there's some new trials that have been presented, and they're really important, and I'm not sure everybody knows about them. And tonight is the day to learn more about them and to dive deeper into the data and discuss it. And then later we'll talk about tricuspid, because there's a ton of new data in the tricuspid arena and so much to learn and talk about. So with that, let's start the program. Can we get the agenda up, or we'll just move right on? So first, we're going to talk about Reshape HF2. Is it a tiebreaker? And the cluster analysis from Andy Morse.
Thank you all for taking time out of your evening to join us. I'm Andrew Morse. I'm from Nashville, Tennessee. Glad to be part of this. Glad to be part of this day. The last 2 days have been pretty exciting. Interesting to see all the data unfolding. I think there's more and more data accumulating, especially around edge-to-edge therapies in the mitral and tricuspid space. So with that, we're just going to jump into it. So Reshape 2, is this truly a tiebreaker? So we're all very aware of the 3 large randomized trials of looking at edge-to-edge repair combined with GDMT versus GDMT alone. And sorry?
Carry on.
Okay. And the ability to look at all 3 major randomized trials that were done here. So COAPT being on the far left here, which was sponsored, 614 patients randomized. MitraFR. Sorry, we're doing a screen adjustment real quick here. MitraFR, which is a physician investigator-initiated trial out of France, which had 304 patients, and then Reshape 2, which is the topic of discussion this evening, which was also a European-based trial of 505 patients. Most of these trials started in the early 2010s, COAP starting in 2012, and then Reshape starting in 2015. Some people ask, well, why Reshape 2? Because actually there's a Reshape 1, which I think enrolled 43 patients, and then closed due to trial enrollment and a variety of other reasons, my understanding. So in these trials, there's one-to-one randomization of edge-to-edge repair with GDMT versus GDMT alone. And Reshape 2 showed some pretty powerful results with this. They showed a composite decrease in mortality combined with heart failure readmissions alone, and also a pretty robust improvement in the KCCQs. We get a lot of questions around these quality of life, and I actually am curious to see what the panel thinks overall with this. I might pause and ask this question. KCCQs with this, is 11 points matter? Saibal, I'm going to pick on you. Does 11 points improvement in KCCQ matter to patients?
Yeah, I think it does, because usually the threshold for any change is 5, and I think number 10 is actually quite significant, even though in TRILUMINATE it went to 15, but I think 10 is considered to be by heart failure trials. Correct.
One thing that was pointed out is a lot of the drug trials, whether it's the Jardiances and Trestos of the world, the ARNI SGLT2 inhibitors, the KCCQ improvement in some of those trials was around 4 or 5. And so to have a device therapy, which is a permanent, doesn't matter whether you take your medication or not, to have a significance of over 10 was pretty important, and patients truly do value from this. So these were very different groups of patients, and we'll get into that. The COAPT group and the clinical endpoints they were able to achieve were remarkable. It was the first trial of its type to reach hard clinical endpoints, including heart failure, mortality and heart failure remissions, mortality alone, as well as quality of life with this. MitraFR, however, did not meet those endpoints, and there's a variety of arguments and reasons why people believe that this is the case, which we'll get into somewhat. And then Reshape 2, which was a different patient population as well, did show heart failure reduction, mortality combined with heart failure, but not a mortality by itself improvement. Quality of life was also substantially improved, as we showed out on the prior slide. So these were different groups of patients from an anatomic standpoint as well. The co-op patients, you can see in the far upper left there. So on the X and Y axis here, you have ERO-A, which is representative of the severity of mitral regurgitation, and then you have the LV volumes listed below. So COAPT had patients with a lot of mitral regurgitation and relatively comparatively smaller left ventricular sizes. And if you look at MitraFR in comparison, and this was this whole argument of proportionate versus disproportionate MR that was thrown out in this trial, they had basically larger ventricles with less MR, and they think that this was distinctly different for those reasons, and one of the arguments why the trial's outcomes were so drastically different within this patient population. Reshape 2 was kind of interesting in the fact that you had less MR with EROs that approached 0.2, smaller LVs, but you did show the benefits of heart failure, hospitalization, and symptoms. Mike, what do you think about these three patient groups?
Yeah, I think it just reflects real world, right? So in any randomized trial, the results apply to the population you're studying at that moment, and then your job as a clinician is to figure out how does it apply to my patient who's sitting in front of me right now. And this additional data gives us another point to help us understand how your patient is going to do. But what I think this tells us is that very end-stage ventricles with borderline MR are probably not going to help. But for the majority of the patients who have not end-stage ventricles and have real MR, that there is the real possibility of helping them.
Great. When you look at a meta-analysis of the three trials, and you're able to break it down once again for heart failure hospitalizations and mortality and other clinical endpoints with this, you can see that unplanned heart failure hospitalizations within the 2 years favored edge-to-edge repair. Recurrent events, including heart failure or all-cause mortality, favored MitraClip edge-to-edge repair in the first 2 years. But there's no difference between the observed cardiovascular or all-cause mortality, although there was a trend in that direction across the line of unity. So there's this argument that there's a large degree of heterogeneity, as we pointed out, between the trials, and that these were three different subgroups of mitral functional MR patients. And because of that, it showed different outcomes. And there's future planning for patient-level meta-analysis to be done that may be able to provide a totality of the data to get some insights with that. So with that, I'll pause. Any comments from the panel?
I would say that one of the things is sometimes you can't tell whether your patient is a COAPT patient or a MitraFrance patient, but it's safe either way. So there was no penalty to doing the procedure. It was there's going to be various degrees of number needed to treat to help, but you're not hurting. And so if you're not sure, I think the coin flip goes to clip.
Mm-hmm. Do you all view that Reshape 2, given the light of the data, not only from the presentations at ESC, but also presentations here, do you think that this pushes us in one direction or another? Does this add to the data pool here in a meaningful way of groups of patients? One thing that came to my mind is that, the amount of MR that was researched in Reshape 2 was substantially less by ERO consideration than the other two trials. And the question in my mind is, where do we head with these patients that have functional MR and moderate mitral regurgitation? Is there a clinical benefit? There's been some publication around this. There's been some data from EXPAND. There's been some other interesting things. And then how do we grade it? Do we grade it by transthoracic, transesophageal echo? What is going to be the gold standard for which we define trials that move forward? I don't know if there's other thoughts from the panel about Reshape 2 and its impact on clinical practice and what we're going to do as a society moving forward.
Yeah, I'm happy to make a comment on that. I mean, it's, like a lot of things, these are echo-based trials. You've got to get the echo right, and if you quantify right, and the quantitation, just to clarify, is based on volumes. We're trying to get volumes in EOA, and that's the standard. You're not quantifying necessarily the prognosis, you're quantifying the defect. But then you have to recognize the prognosis matters based on the LV and the subset. So, the same amount of MR in a MitraFR patient and the same amount of MR in a COAPT patient might be a little bit different, or in a primary MR. So it gets challenging to recognize what it is you're actually quantifying. But I think it's an important additional study Reshape 2 simply because it's sort of, the population is closer to the COAPT. So it adds more data that, yes, this is a patient group that is fundamentally can be helpful. And I think that's what we're learning with this data.
Okay. With that, I'll move
Well,
forward.
the other thing is
Okay,
that
sorry.
in Reshape 2, their medications were actually, they were a higher percentage of people were in ARNI and SGLT2, which was not in COAPT. And the second is that the absolute mortality in the control arm was actually very low, 9%, so they took less sick patients. The absolute mortality in the COAPT arm, control arm, was very high. So what we really took patients was sicker patients. And just based on a trial design, if you have a sicker patient, there's a higher chance you can show a benefit. If you take less sick patients, to show the delta is a little bit difficult. So that's why they probably couldn't show the mortality benefit at 1 year. Maybe if they waited for 2 years, it would be. But at least they showed heart failure admissions clearly superior. I think COAPT and Reshape 2 went in the right direction. MitraFR was slightly off chart, but that's because it had, at the end of the title, MitraFR. I know Sandra's sitting over here, and Sandra's French, and she's all pissed. I'm just joking.
I'm going to leave that alone.
But they make good. But France makes very good wines.
Yeah.
But Andy, I think it's worth noting that, what was it, 23% of people in this trial had an
Yeah.
EOA of less than 0.2?
Yep.
And only 14% greater than 0.4? So it's really a distinct group, and with their LV sizes, this may represent that continuum of people who are fairly well medically managed. Their MR is a little better, their ventricle's not normal by any stretch, but yet when you treat them along that spectrum, you still can get benefit, especially the main benefit here was cardiovascular hospitalizations. So, all these things are additive because they teach us, but I think it's a really, 60% had moderate MR.
Yeah, I just want to add, I think all three clinical trials are really, really important. Think for a minute, if we didn't have mitral FR, there would probably be an immense amount of indiscriminate use of mitral TR. And I think what these clinical trials remind us is just how important it is to identify patients, treat the right patient subset, and have a heart team approach with adequate imaging, adequate quantification, adequate medical therapy. So it's quite impactful. When you see both trials and the impact and the difference, it really just boils down to patient selection, which is critical and it's important. It just reminds us of how we should be taking care of these patients and selecting them accordingly.
Yeah. That's a great comment. We're going to move forward here. I definitely appreciate Mike's comment about the fact that this is a safe and reliable procedure. And so as we sort through this, I don't think that there's a downside for a lot of patients with this procedure that negatively impacts them from a procedure risk standpoint. So that's been reassuring. So the next thing we're going to jump into is phenotypic diversity in COAPT and MitraFR patients and the cluster analysis done. So in this analysis, done by Bonnet colleagues and presented at New York Valves, they looked at phenotypic diversity and outcomes of mitral edge-to-edge repair and secondary MR. And what they aimed to do, and I was trying to actually sort through if they were just plugging this into ChatGPT or what was happening here, but they were doing this unsupervised clustering model in which they took 22 baseline variables, some were patient variables and some were echo variables, and plugging them into this algorithm in order to try to separate the groups of patients into three distinct groups, cluster 1, cluster 2, and cluster 3. One thing to note is that in these breakdown of COAPT and MitraFR patients, that the way in which they're classified between cluster 1, cluster 2, and cluster 3 was vastly different between these two patient populations of how they are segregated. So with this, we look at the outcomes of patients in the MitraFR cluster. So cluster 1 is patients with low surgical risk, low comorbidities, and early stage cardiac damage. And by cardiac damage, it's LV remodeling, LA remodeling, RV remodeling, and then RV and PA uncoupling that tells you the degree of cardiac damage done. So in this Group 1 here, you saw a distinct improvement in patients that got edge-to-edge repair versus GDMT alone. In Group 2, which was defined by high surgical risk, moderate to high comorbidities, and advanced stage of cardiac damage, they also benefited to a degree by having edge-to-edge repair versus medical therapy alone. But you can see the poor outcomes of these patients, despite all these things, at over a 5-year time window. The next group of patients, which is the one that's more hotly debated, is this cluster 3, which is basically high STS score for surgical risk, high comorbidities, and no or low cardiac damage. So people who do not have evidence of cardiac damage with this. And this group of patients, which was about 50% of the patients in MitraFR, they did not show a clinical benefit by doing edge-to-edge repair in addition to GDMT as far as cardiovascular death or heart failure was concerned. Any comments from the group about this analysis? I thought this was really interesting about the patients on the right in particular. What are your thoughts on this?
I mean, it really speaks to the importance of the comorbidities. The highest comorbidities, and it doesn't matter what you do to the MR, they're still going to deal with the comorbidities, and they're going to succumb to the comorbidities. So I think that's the message. If, the ideal person is just a cardiomyopathy with a secondary MR and anatomically clippable as they usually are, but they don't have renal failure and they're not on dialysis, and all the other things are missing, then they do very well, and that's the blue group.
Yeah. I think that was hit home in the fact that, like you said, these people in Group 3 die for other reasons. They have something competing in the background besides their functional MR that is creating this poor outcome for them. And so understanding that these groups are different, I think sheds more light on, once again, more data to help support our decision-making with this. So, Mike, go ahead.
Yeah, I would just say that, again, what you can see there is sometimes you can't tell, is my patient blue, orange, or green? And sometimes it's clearly that green group. You're like, oh God, they're not going to make it out the hospitalization. But there are some patients who you're not sure, and again, there's no penalty, other than they went through a procedure they didn't benefit from.
Do you guys think that this is where the future is headed? We do all this type of risk scoring, we do these assessments of their echoes, we do all of these things, but do you think we're headed to a future where we're going to plug a patient's demographic in their echo, and it's going to spit out a number like this and tell us about their longevity, about their outcome? Do you think that that's where this is headed?
Well, I think there's another scoring system which people don't talk about. It's called common sense, which is actually a rare sense.
That's rare.
And I think the best way to score a patient is to see a patient, examine a patient, take a good history. If a patient's, like half dead on the bed, I wouldn't treat him with anything. But if the patient was functional till 2 weeks ago, and now is short of breath, and doesn't have any major comorbidity, you treat the patient. So I hate these scoring systems. Actually, I'm against scoring system, but I like people to use a clinical judgment to treat patients. But that's me. I'm just an ordinary clinician. I don't understand these complex mathematics.
Got it.
Just to add, we have to understand this data and interpret it, because I see there's fellows and others in the room. The fact that a Kaplan-Meier curve doesn't show an impact on mortality in mitral FR does not mean that patients in that trial benefited from mortality. There may be a bucket of patients within that trial that did benefit from mortality. So, and again, it goes back to what Saibal just said. You have to individualize therapy, and that's what, as clinicians, we need to do best. I hope that these AI models help us and facilitate, but at the end of the day, I think nothing overcomes clinical judgment, hemodynamic numbers, echocardiographic data, and disease progression over time.
Okay, so I think we should probably move on to our next speaker, and thank you.
Yeah,
Excellent.
thank you.
Next is Dr. Mark Ricciardi, who will talk about atrial functional MR, which I think is a really cool topic, understudied, but maybe not now. And then we'll talk about Matterhorn.
Great, thank you. It's a good crowd. It's a good number of people, a lot of smart people. So let's talk a little. So I had the opportunity to present this data to the HFSA, Heart Failure Society of America. which is pretty fun. I like their format and how they present late-breaking trials like this, so I wanted to share that. So on the left-hand side of the screen here, we're talking about atrial secondary MR. These are folks with severe mitral regurgitation, and this is a subgroup who have pretty preserved LV systolic function and enlarged LAs, and therefore dilated annuli. And I think, as was noted just now, there's little known about this subgroup of people, not just pathologically, but how they respond to therapy. So the thought behind this trial was to take a pooled cohort of people from the EXPAND registry and the EXPAND G4 registry and put them together into this expanded group cohort. The EXPAND had not only echo adjudication, but also a central committee to assess clinical outcomes. EXPAND G4 had adjudication for the echoes, but not for clinical events. But pretty good group of people, and within that group, we then separated them out and defined this atrial SMR group as those with ejection fractions of greater than 45%, atrial fibrillation, and the criteria there for enlarged LA. And those are the people who were studied. And so what we learned were a few things here. This is not on the slide, but there was 0% mortality in this group. There was 0% conversions to a mitral valve open operation, and just one stroke and one SLDA in the entire group. And you can see there the atrial SMR folks at 1 year had heart failure hospitalizations that were reduced by over 50%. This compares favorably to the group on the right there in that I don't know what color that is, green-blue. Very similar to the overall secondary population, which we're now kind of more comfortable with. And on the right there, you can see that all-cause mortality, I mentioned that procedural mortality was 0%, but if you follow them out to a year, the all-cause mortality was 9% for atrial SMR, which is a little less than the typical all-comer SMR group. And then what about changes in MR? So also not on these slides are the quality of life outcomes here. KCCQ was mentioned earlier. I think it's a great point that Andy brought up, what's a meaningful change, but in this trial it was a 19-point change in that score, which is, 20. When you get to 20, you're believing it, and there are a lot of correlations with more meaningful or harder outcomes when you get up to the 15 to 20% ranges. 19 points, and the functional class improved tremendously. But here's MR. So we're here mostly to get rid of MR, and you can see here that 95% had MR that was 2+ or less at 1 year. So the acutely there was a good result, and then at 1 year was a good result. Again, this compares favorably to the overall SMR group, and you'll know, a lot of people in this room are very experienced, you'll know that there's always been some talk about whether atrial SMR was a little more difficult to treat with edge-to-edge repair than a ventricular SMR, but this suggests that we can get very, very good results with TIR. And so the conclusions from this trial were essentially what I mentioned, which is that we have very, very low, and it's been mentioned a couple times, probably re-emphasizing, especially in this subgroup of people, that procedural deaths are non-existent, stroke and SLDAs are very rare, and you also get great quality of life improvements in these patients, functional class and KCCQ. You were able to reduce their mitral regurgitation in 1 year, 95%, you get 2 or 1+ MR. There was a reduction in LV volumes, which we could talk about a little bit as well. The mortality was low, 9% at 1 year, and the heart failure hospitalizations were reduced by over 50%. Thank you. Do you want to take some questions about this, or comments preferably, and then I can talk about MATTERHORN? Yeah, please, Steve.
I just want to really amplify that message about 98% technical success. I think that's remarkable, because there is this sort of notion that atrial MR is tough because there's annular dilation without ventricular tethering and perhaps not enough coaptation reserve to do an edge-to-edge repair. But 98% technical success is amazing, so I think that just sort of pops that balloon.
Yeah. And core lab adjudicated, so not just what we wanted to show, but what others thought they saw.
Given that comment about coaptation reserve within these leaflets, when you have a flat, stretched annulus and flat leaflets, does it change your perspective on clip choice? Do you guys look at it in a different way than you do standard functional MR, where the ventricle is the problem? What do you guys tend to do? What were the trends here, and what do you guys do nationally?
Yeah, so I'll just answer from the standpoint of the trial, which was, only half of these were G4. So it was, in fact, it was probably less than half. So G3, you didn't have some of those options. But I do completely understand what you're saying, which is that, maybe you should not attempt to gather as much leaflet and use, quote, smaller, shorter devices. The average number of clips in this trial was 1.4. And remember, you used to always talk about whack-a-mole with atrial SMR, but 1.4 is the same as the general SMR group these days. It used to be 1.7, 1.8, 1.4. So, so the breakdown was mostly NT or NTWs in this.
Remember, it's not a trial, it was a registry. And these patients were treated by the physician who felt that the clip would work. So the biasness is that if it was very difficult to treat, they probably excluded them, right? So it doesn't pertain to all atrial functional MR.
I think there's not great medical therapy for atrial functional MR. You try to put them in regular rhythm, you diurese them, and maybe now SGLT2 inhibitors, although that's not been formally studied in AFMR. So do we need any more trial evidence, or is this enough? I think it's enough. I don't think we need to put patients through a randomized trial, but maybe others feel different.
Anyone in the audience or people would want another study on atrial functional MR? And I wouldn't know what you randomize it to, right?
We should move on.
You don't want to see the answer to that? No, I think everybody agrees. And there is a lot of data in heart failure preserved ejection fraction, but these are distinct patients. It's not, so the SGLs and stuff. So let's talk a little bit about Matterhorn. So this is a study I know nothing about except for reading it. I didn't participate in it. I'm not German. Well, I'm partly German, but I don't live in Germany. And this was a study, it was a non-inferiority trial of TR with MitraClip. For secondary MR, comparing it to open surgery. And I think it's interesting why you would compare a TR to, in a non-inferiority trial to a therapy that is considered inferior in general. But this is what the thoughts were in Europe. You had to be high risk to get a TR with secondary MR at the time of this trial. And you can see there below 200-something patients were randomized, this randomized controlled trial to surgery or mitral TR. The primary endpoint here, you can read this, but meaningful primary endpoint, efficacy endpoints were shown here, and you can see there was a significant improvement, or I should say, a non-inferior outcomes when you looked at event-free survival for TR versus surgery, but numerically, event-free survival is better with the TR device than there was with surgery, not too surprising. And then secondary, primary endpoint, which is safety here, which was just markedly different. There was a 60% reduction in adverse events. Again, not very, very surprising. Gentle procedure versus an open procedure. I think not on this slide is a couple things that I found interesting, which was that there was a 4.3% in-house mortality with open surgical repair or replacement. 70% essentially got repair and the rest got replacement. 4%. They were in the ICU for 3 days and they were in the hospital for 12 days. MitraClip, 4 days in the hospital, 1 day in the ICU during the time of this trial, which is 2015 to 2022. And so you've seen similar slides to this, but you can see where Matterhorn ends up on this graph compared to some of the other trials we've talked about tonight. Essentially, at the end of the day, these are people with relatively small LV and diastolic volumes and really relatively moderate MR with EROs in the 0.22, 0.23 range, whereas remember MitraClip was probably over 0.3 with volumes very similar, less than 200, and then MitraClip is the outlier here with end diastolic volumes of 250 and MR more in the 0.3 range. So this will be presented, I think, what's the 30th? Is that tomorrow? Wednesday. It says Wednesday right there. This will be presented hopefully in a little more detail by the group that performed the study. So yeah, any thoughts about this? I'm curious what your first reaction was when you saw that they were studying this. Was it like...
So I actually got to review this for the New England Journal of Medicine, so it
good.
was kind of cool. So I got to see it a while ago. And a couple of things I thought were interesting. One is that the EFs were not that low. So these were like...
43%.
Yeah, that's not a bunch of 25%. These are surgical candidates.
Yep.
And CLIP did very well and was safer than surgery,
Yeah.
as you would imagine.
Totally.
Surgery did okay. So the way I would look at this as yet another study that is, suggests that treating the mitral insufficiency is probably the right thing to do, that MitraClip is the right thing to do, that even surgical candidates, MitraClip in secondary MR is probably the right thing to do. If they don't have anatomy that is conducive to MitraClip, surgery is not wrong. I mean, that's the way I spun this.
No, yeah, I think that's a good, wholesome way to look at this. I saw it like, I speak to people whose default treatment for secondary MR is surgery. I know, when you get on a dais like that, so that's probably not at a lot of the institutions we practice in, but I think it's still real that the gatekeeper remains the surgeon, and they'll take the patient if they want, and it's a tier if they don't want. But I really think that if there's any question about that practice, which is really a 2B indication, surgery for secondary MR, this pretty much argues that the TR option is as good, not inferior, and arguably when you look at the safety endpoints, superior.
I think that isolated surgical mitral valve surgery for functional MR is a dying thing in the United States. The overall numbers are extremely low. At our center, it's almost last resort unless concomitant with coronary bypass or double valve or some other procedure, but in isolation, it's very, very low. And I guess my question for the panel is, do we truly believe that these patients were high risk based off of their Euro scores and STS scores and their patient profile? Do we think that that was the aim of the trial, but do we believe that they were truly categorized as high-risk patients?
Yeah, that's a great point. So the STS was 2, Euro score was 3 on this, even though the inclusion criteria was high risk. They didn't include frailty or anything like that. So these were not considered particularly high risk, and I think Dr. Rinaldi was sort of touching on that a little bit.
I think it's also important to point out, what was the surgery, right? The surgery typically in a repair is just an annular surgery with annular reduction, and no neocords, no effort at working on the coaptation. So the clip actually has an advantage. You create coaptation. The surgeons may not. So one of the dirty secrets is, functional mitral repair doesn't have good outcomes. They don't look good at 2 years. The LV continues to remodel, gets pulled apart again. The annular reduction isn't enough typically. So I think it's important to recognize that repair of primary MR is a different beast. Repair of secondary MR is probably very inferior to begin with.
Yeah, that's a great point. Good, move on?
Thank you.
Great, thanks, guys.
All right. This was a very quick and session on some of the important things. We could go on forever. I just want to acknowledge some people in the room. Sandra, thanks for coming in. And she's the new head of structural. And for those people who don't know in this room, Fredson Gore, you're going to stand up, okay? How many people over here know Fredson Gore? He was the inventor of the MitraClip, and today we run. Many, many years ago, nobody believed us, and now it's like standard of care for everything. All you need is a femoral vein and Medicare insurance, and then you get a MitraClip. So we just want to summarize all the data, and Sarah, thanks for arranging this wonderful symposium. To summarize over here, you can see that we talked about 3 trials, Reshape, Matterhorn, and then we talked about COAPT and MitraFrance. What we have to say is that the MitraClip as a device has been probably the most well-studied transcatheter treatment option for MR. And this is a great effort from Abbott that they did this. And what is beautiful about it is that if you look at all the 3 trials, number one, it's been shown to be extremely safe. Everywhere you do it, whether you use it in Europe, whether you use it in the US, that's one thing. Number 2 is shown that in functional MR, even for moderate to severe patients, or severe, they did well. There was definite reductions of heart failure, which is very good. There was in COAPT, which was a much sicker population, we showed a dramatic reduction of mortality. And in Reshape, where the overall mortality was lower, they clearly showed an improvement in heart failure. The MATTERHORN study, which took patients and randomized them to surgery for less sick patients with similar disease, showed that clearly surgery had higher serious adverse events post-surgery, right? But the overall improvement was not so bad. So it's good to say that, if they're good surgical candidates, you can do surgery. But if you look at the risk-benefit ratio totally, it favors edge-to-edge repair. So what we looks like, to summarize, that edge-to-edge repair should be done for all patients. whether you have MR or not. You just have to have femoral vein, a Medicare insurance, and then you get it. I shouldn't be saying this. This is an Abbott symposium. Tomorrow I'll be in trouble. I think.
Is this being recorded, by the way?
Yes.
But
for the
Saibal,
gen-
it turns out that you don't actually have to have MR because you can now use it for a different valve. And
That's
we're gonna
right.
actually
I
talk
forgot about that.
next.
Exactly.
See what I did there?
What a segue.
And so that leads us to go to the next session. We're not happy just treating the mitral valve, and now we can see we should use it in the tricuspid. Thank you very much, by the way.
So we're going to actually now move on to our tricuspid session, which is super exciting because we have so much going on in the field of edge-to-edge repair. So we're going to start again with my esteemed colleague, Andy Morse, and he's going to show us a case of tricuspid edge-to-edge repair with TriClip, and then we're going to talk about data, and then we're going to go back to the case.
Sounds good. So we'll jump into it. We had the privilege of being part of the IDE for TRILUMINATE and ultimately led to approval, and then TRILUMINATE continued access. Mike, if you want to jump into here about the timeline.
Oh, yeah, I have to do the timeline. Thank you.
Go ahead.
Sorry about that. So, in brief, we started with MitraClip. It was approved, and then we actually started TriClip back in 2017. It's been a while. It's actually been a journey. And the pivotal trial started. It was approved in Canada and the EU before the US, so they've had more experience and more time than we have, but we're now catching up robustly. And now it's approved and commercially available. There have been a number of studies out of Europe, and now the TRILUMINATE clinical trial that you were part of and I was part of, really a monumental trial. And so here we are with commercial work this year. And you know the tricuspid clip system, it's the same clip, but a different delivery system. The differences are about knobology and what knobs are on the guide versus the system, but it's very familiar. The important thing is if you know how to do a MitraClip, then the transition to tricuspid clipping is fairly similar, and actually the hardest part is from the imager's side. So, but it's all translatable. Next. And so, what did we learn from TRILUMINATE? We learned that it was a very safe procedure, that we were able to reduce tricuspid insufficiency in a whole variety of patients from the randomized patients to the registry, and that it improved quality of life substantially. Actually, my nurse navigators who see a lot of my patients after these procedures tell me that of all the structural procedures, the patients who got tricuspid clip felt the best, which was actually surprising to me and remarkable, but probably in retrospect shouldn't have been surprising. So let's see your case.
Yeah, so full disclosure, we were one of the early adopters for off-label and miskeying the device, the so-called Munich steering technique, and we were doing dozens and dozens of cases off-label. So when we finally got access to something that was dedicated to be used in this way, it was literally like a breath of fresh air because we had so many hard, long cases trying to understand this that now we had a dedicated platform to use. So we became quickly believers of it. So my patient's an 84-year-old female who had progressive heart failure symptoms over the past couple years. She's going to have severe mitral and tricuspid regurgitation, which is a whole other group of patients that we've yet to delve into about how to handle these situations. But we chose to treat the patient initially with the MitraClip in January of 2023. Then we subsequently, had persistence of severe MR and enrolled them into TRILUMINATE Continued Access. I'll get into some of the anatomy here with it, but the patient's coaptation gap by us was 6.5. I think by core lab adjudication, it was closer to 8. The patient's right ventricle was not severely enlarged. They had a pretty large right atrium, and they had no leads in place. It was ultimately graded to be torrential. So here are some of the baseline imaging. So on the mitral side, just a 3D view of the prior edge-to-edge repair, 1 to 2 plus MR is what this came out to be with this. As far as our baseline imaging here, we did X-plane imaging for all our cases, looking at inflow, outflow, and then intention to grasp views. These are kind of our setup shots for what we want to do for planning our procedure. We do it without color, and then we scroll through with color to try to define the pathology here and define the anatomy. Any comments from the group here about the initial gut reaction to those first 2 sets of pictures?
Yeah, so from a TE perspective, clearly there's a lot of a lot of TR. Yeah, I understand why some called it massive, some called it torrential. It's clearly more than severe, so it probably doesn't matter that much. Now, the coaptation gap, really the right image is sort of the implant view typically, and you want to know if you can get there. I think the measurement was 6.5 or so, so it's doable. It's on the high end, but you know, I think if you would start probably commissural between the septal and the anterior, and then maybe clip and zip and move your way towards the middle, bring the coaptation gap closer and closer. So, you know, anticipating probably at least a 2-clip case, but doable.
Yeah, and quadricuspid is just not that rare. Turns out it's not always a tricuspid valve, it's a quadricuspid valve.
Yeah, it was amazing. It's like we didn't understand that tricuspid valves are like snowflakes. They're all very different and unique in their own way, and they all present their own unique challenges when you look at them anatomically. Two things I want to point out here is, number one, if we just go back a slide here, if I can get it to play here. So here you can see actually some prolapse of the valve. It's less frequently that we see this kind of myxomatous change routinely. Most of these are pure functional tricuspid regurgitation, but this patient had probably a component of functional and degenerative tricuspid valve disease. In addition, you can catch a glimpse of it in the top left panel there, that there's an ASD. And the question, because we did a right heart cath with the QPQS, and we said, should we close this? Is this contributing in a bad way? Because we see sometimes these persistent atrial septostomies, and we ultimately found a QPQS of 1.1 to 1.2, and so we said, we're going to leave it alone. Is that the right thing to do with a patient with severe MR? We don't know. We've done closure and then reassessed and come back and done this in these type of patients, but I guess, you know, the overall mechanism to our eyes was that there's a component of functional and component of degenerative, which was interesting in this case. There was a lot of TR here, and the question was, what type of result are we going to get? And then, you know, I don't know if you guys have other thoughts about these persistent ASDs. You'll see after you do the mitral and you come back for a stage tricuspid, we, in general, don't do concomitant together. I don't know what the right answer is for that. Surgeons do it all the time, but we tend to stage them for a variety of reasons. But I guess two questions to the group is, number one, would you do anything different about this ASD with the QPQS 1.2? And number two, would you have done this patient mitral and tricuspid together in the same sitting?
Yes and yes, just to be provocative. But at the time of the original mitral repair, there was a ton of TR. Do you
Yes.
remember? Yeah.
Yes, there was the same amount. It didn't really improve with mitral being
and you
fixed.
had left to right shunting across your iatrogenic ASD. And so I'm sure you gave some thought to further volume overloading this right heart. And we can talk about PA pressures and how big the RV was and all that stuff, but we do try to give some consideration to that, since adding a septal closure at the end of a MitraClip is really very straightforward and safe. So we do think about that a little bit, and I think that my second yes was, would we have repaired at the time? And it depends what year it was, but now that we have the TriClip system, I find it much more difficult to use the MitraClip system to repair the tricuspid valve when I know that I can bring the patient back with a dedicated device, which I find much, much better for repairing. But, you know, you don't have pacer leads here. You've got, looks like great imaging. You didn't show us a transgastric and all, but except for being a lot of TR, I think there's a lot of favorable features in this case.
I think you got, you know, it depends on how quick your procedure goes. Someday we may have a dedicated system that does both, but I think you also have to think about, you got to give the patient's esophagus a break if it was a long case, and also there's operator fatigue, but it's feasible.
Yeah, I think with the straightforward functional TRs that we see in combination with mitral regurgitation, we give them a chance to see if it's going to improve. I don't know what the overall, you know, trajectory of these patients is, but we find, you know, it's like a third get better, a third stay the same, and a third get worse over time. That tends to be the flavor of what we see, but this patient had a degenerative component of myxomatous disease of their tricuspid valve, so we looked back at it and we said, did we make a mistake? Did we do something different? But at the time, we wanted to get access to TriClip, so we enrolled them into TRILUMINATE registry because that, but today, I don't know if I would treat it differently or not. So our imaging here, Dr. Raisi, who's sitting out here, was our excellent interventional echo, really produced some fantastic images. We don't always have the ability to achieve these images, and we've been a big proponent of ICE. We use it probably in 20 to 30% of cases now. I think that's because we're trying to learn and understand where it's going to play a role and where it might not play a role. It does have added economic stress to the system, but that being said, sometimes it provides for a cleaner and better outcome for the patient, which is ultimately what matters. Here you can see our gastric views, which are critical for the procedure, and then a correlated 3D color view. Any other comments about the echo here as far as strategy? I think we mentioned starting anterior septal and working your way maybe mid to central here. It may be 1 or 2 clip strategy. How many clips do you guys think would be required here?
I agree with Steve. I'd go for probably a 2-clip strategy. We usually start anterior and work our way backwards, so probably start anterior septal and then maybe P1 and septal and see what you get. But that sounds reasonable, and I do think this is a great TEER case.
So here we've been doing multiplanar reconstruction. It's been our go-to for a lot of these procedures, whether it be for edge-edge repair or replacement, and setting up our imaging to do that has been key. I think all agree that this was a good case for TEER, hence why it was approved by the panel at the time. With that, we're going to take a pause in the case and jump into some data.
Okay, great. Now we're going to talk about the TRILUMINATE Pivotal and the TRI.Fr, which is not the same as MitraClip.
Right.
All right.
No, you can, wherever you want.
I guess I can stay here. Yeah, so what does the data show? I mean, you just presented a great case, and so what do we tell our patients? And what does the TRILUMINATE data show? So I get to share a few slides here, and I want to thank Abbott for this wonderful occasion and Sarah for helping us with the slides. So just to recap, TRILUMINATE Pivotal trial was the first, okay, let's underscore that, the first randomized controlled trial really to evaluate TEER in patients with severe tricuspid regurgitation compared to gold standard, which has really been just guideline-directed medical therapy alone. So a very remarkable and pivotal study that is now available for our patients. And this was, as you guys recall, published in New England Journal of Medicine. The primary analysis initially included 350 randomized patients, but we just heard Sunday the additional data cohort with over 500 patients, which we'll review. And it found that TriClip, the TEER system, was superior to medical therapy. The primary endpoint of the study was a hierarchical composite of all-cause mortality or tricuspid valve surgery, heart failure hospitalizations, and quality improvement scores, as shown, and those are your inclusion-exclusion criteria. And this is the slide that, for those that maybe missed the presentation just a couple days ago, it's just a nice presentation that Gilbert gave at Dr. Tang, looking at the 1-year outcomes for the full TRILUMINATE Pivotal trial cohort, which was quite remarkable and exciting to hear. So if we look at the primary endpoint for the full randomized cohort that included 572 patients, we see win ratio in favor of tricuspid valve TEER. As shown, perhaps largely driven by the Kansas City quality of life questionnaire, but we also start to see in subgroup analysis some hospitalization improvements. No difference in all-cause death or tricuspid valve surgery. So the device subjects had 84% more likelihoods of having a better outcome when compared to the control cohort. This is a subgroup analysis looking at, we've got here on the left, freedom of mortality. So we know doesn't appear to be a signal of mortality benefit when comparing tricuspid TEER versus guideline-directed medical therapy, but it's also good and important to emphasize that there's no signal of harm, which is important. And then we start to see 2 of the secondary endpoints here as shown, annualized heart failure hospitalization rates in favor of tricuspid TEER, first signal with the total cohort of over 500 patients. So we can now share with our patients, at least in the later part of the trial, we're starting to see a signal of benefit for hospitalizations, and the signal for quality of life is much larger with the total cohort compared to the 300 plus initial presentation back in ACC. This is I'm just going to move forward here. This is just a segment of the same slides showing an improvement in TR reduction as well, sustained over time. And this shows us that very nicely. Here we see the device group on the left, remarkable sustained TR reductions with the full cohort, 200 patients in one arm versus 206 in the other arm. And you could see 88% or more reduction in TR sustained over 1 year for patients with tricuspid TR. So quite remarkable results and with important TR reduction over time. This is just a slide that reminds me of the registry cohort that ran in parallel with the TRILUMINATE, which is the single-arm registry, 100 patients. And this was mainly a registry for higher risk patients with complex anatomy that were felt to be non-ideal for randomization. And the purpose of showing these slides is, what did we learn from that arm? What did we learn from the single arm that had patients that were a little older, that had higher rates of, pacemaker leads, and with that, larger coaptation gaps, larger right ventricular volumes, et cetera. And so how do those patients perform? So when we compare the single arm cohort with the randomized cohort, we see actually very similar outcomes. And so despite the investigators fearing to enroll these patients in the randomized arm, we see that the single arm cohort with complex anatomy did just as well. So that's, I think, really telling as we dive into patient selection. We can take on maybe more complex cases and obtain similar results, at least when it pertains to TR reduction and response and quality of life improvement. And importantly, the safety endpoint, as you can see here, are quite remarkable. I think one of the things we all love about this therapy is the fact that we feel like we're not really hurting patients, and that these patients all tend to have an outstanding safety profile. So that's quite encouraging. This is presented at TVT earlier this year, and it was a sub-study looking at 316 patients. And basically, in each column, you get to see that, what is your predicted mortality, device thrombosis, and reintervention rates in patients with 4 valve leaflets, so quadricuspid valves, in patients with coaptation gaps of greater than 7 millimeters, or patients with prior RV pacer leads. As you could see here, the all-cause mortality was low. Device thrombosis, arrhythmias, bleeding complications, and conversion to surgery were all very low, so suggesting that it's safe even in this population of patients. And this is the TRI.Fr study, which was, just to remind everyone, a randomized trial with 400 patients comparing similarly guideline-directed medical therapy versus TEER, and we see a 71% reduction in moderate or less TR over time, suggesting efficacy and outstanding results. So with that, we're going to take it back to the patient. And Andy, I do think that, do you think, of course, this patient was accepted in the trial, so I think this is right up the alley, and I think the results of TRILUMINATE support clipping strategy.
So let me ask Dr. Little, how would you have rated this? Is this somebody who should have been accepted into the randomized arm or the registry? Or is this a harder case or a straightforward case? And, in the background, I also wanted to make a comment that I think that 1-year data is very important, because there's no guarantee that that in the tricuspid space, this is going to be durable like we see in the mitral space. But at 1 year, at least, that's very encouraging that we have durability. So safe, doesn't cause pacemakers, and effective, and so far at 1 year, durable. So that's pretty important. So how would you rate this is this a hard case or is it a straightforward case?
I think the answer to that question depends when you asked it, because we learned within the trial a lot, and the early calls reviewing cases like this, I suspect it would have gone single-armed early in the experience of the trial, because it was somewhat myxomatous, a large gap, torrential TR, not a classic at the time tri-leaflet valve. But I think in retrospect, I hope it would have been randomized, because that would have been an interesting outcome, because I suspect it was a very nice outcome, and the medical therapy for this patient would have been abysmal, and I think had it been randomized, that would have made the TRILUMINATE data even stronger.
All right, so Andy, what'd you do?
I'm going to steal that.
I'm sorry. Thank you, Andrew.
So we talked about clipping strategy. Our thoughts were the similar idea that we would start anteroseptal and work central into the valve where most of the leak was coming from. We placed a XCW here along the anteroseptal commissure in the mid segment, not all the way out into the commissure area. You can see we're very much in the central mid portion of the valve. Here you can see our gastric view with this, and then you can see our 3D imaging from a surgical view on the right panel. We able to get the initial clip on with a pretty substantial reduction in the TR after one clip with this. And then after releasing, here's your MPR view with this, which ultimately graded to be in the kind of 2+ kind of realm quantitatively. So I guess my question is now, is this good enough? Do you stop here, or do you advocate for a second clip?
Panel, what do you think? More clips or leave it as it is?
More clips.
More clips. It's myxomatous. You don't have a great result. You get a decent result, but it's myxomatous. And, I don't know what the hemos did. I don't know how important it is, but I think for sure, unless you thought there was a downside, put a second device in.
Steve, you saw the slides.
Yeah, I think a risk reward ratio on a second clip is very low. I think there's some potential benefit. You can reduce the TR further. The risk is very low at this stage. I think a second clip makes a lot of sense. Speaking of which, let me jump into these couple of slides. This is super quick. My task was to convince you that TR is bad. So, we know that, the more TR is left, that's bad. But really the question is, if you have already gotten down to moderate, do you need to keep going? And that's, I think, the gist of this case. So severe is bad, moderate to severe is bad. The bright data is shown here. But I think the main message, given that we're getting a little late, is clinically, when you're in the case and you've got moderate, do you keep going or not? Do you need a third clip, a fourth clip? Incredibly rare. There's no data that getting from moderate to mild has additional clinical benefit. So that's important. So if you've gone from torrential to moderate, if you've gone from massive to moderate, if you've gotten more than a 3-grade improvement in your TR, you can stop. At that point, we're probably treating the echo. We're making the color better, which we all want to do. That's the reflex. Let's get less color. Let's get less TR. We know TR is a continuum. But data-based approach to this is mild or moderate TR getting to mild. We probably all want to do it if we can do it fairly quickly, and we usually can. But there really isn't strong data that we need to. So I think that's really the message. Reducing TR to less than mild did not lead to substantially different survival rates. And I think, in the interest of time, we'll keep going back to the case.
While Andy's getting ready, would you argue that the data suggests that going from torrential or massive to moderate is enough, just purely based on the data? I know the patient is anesthetized and all that stuff, but would you argue that just based on the data, that getting down to moderate from massive to torrential is enough?
Well, I think at that point, you've already done a lot of good, right? It's a continuum. There's no, the body doesn't know the TR gradations. They just know the flow and the inefficiency of the cardiac system. So you want to get as low as you can get. But at some point, if you've already achieved moderate, a lot of us, some in this room, walk around with mild TR all the time. So mild TR is arguably normal. Do we have to get there in every case? I don't know. I read a ton of echoes. We see TR in almost everybody.
And I would actually say that, I think there's still role for common sense, as Saibal said, in that, in general, there's what we learned from the mitral side is that if you make it as minimal as you can, you probably have better durability. It's a better thing to do. That may not be true in the tricuspid space, but if it's straightforward to make it better, then you should. But the enemy of good is perfect. But I think, to me, the take-home here is that tricuspid is hard to get to trace, right? I think it's easier to get to milder trace in the mitral space than it is in the tricuspid space. And if you only get 2+ MR, and that's the best you can get, you shouldn't feel disappointed about that result. I am now disappointed with the 2+ MR in the mitral space, but I am not disappointed in the tricuspid space. And that should not tell you, geez, we need a different solution here. Because I don't think we have another solution. There is a replacement technology, but it's not as safe, and you don't require anticoagulation therapy for this. And so I think there's a place for all of it, but you shouldn't necessarily feel bad about 2+ TR. My perspective.
So we chose not to listen to the data and chose to put a second clip. And our argument was the following. Number one, we have short glimpses of outcomes for these people. Do their paths diverge over time? Number two is this patient had a degenerative component, which was kind of unique in the fact that we had to deal with that pathology as well. And number 3 is we've got used to the fact that our patients show up very well optimized because we involve our heart failure colleagues. I can't think of the last time that I've done somebody who was just grossly volume overloaded. We almost always uniformly say, stop, admit, diurese, optimize before putting them on the table. So this is, to me, the best the TR is going to look. And if they have, 2 beers and a sausage, it's going to potentially be worse than what we're seeing on the table here. And so for that reason, we came back and we placed the second clip here. Here's our NPR imaging, slightly posterior as the panel suggested compared to the first clip. We were able to get a very nice grasp here. Imaging was once again beautiful with this, and we're able to place that, like I said, just posterior in the very central portion of the valve here to bring it together. And we were able to ultimately quantitatively bring it down to mild residual TR. Here you can see our final 3D images with our 2 little friendly clips there together with that.
That is excellent. So I think that is now time for some final putting it together. So what did we learn tonight? So I think this is a really cool thing because I think we went over some latest data. This wasn't a rehash of old data, and I find this stuff very helpful to refresh and get new data. So what we know is that first came MitraClip, and now we have the tricuspid clip. We have some randomized controlled trial data and registry data that shows that TriClip is safe, it's effective, it appears to be durable at least to 1 year. It dramatically improves quality of life. We've seen this both in clinical practice, just in our own experience, but also the data shows it. And we're still learning. We're getting better. This is pretty good for something we're all just getting better at. So I think this is a very positive direction and a huge benefit for our patients, something very new. So any other thoughts?
I mean, one other thought I have is, I do want to commend, I know this is an Abbott-sponsored program, but I do want to commend Abbott on the fact that they have the scientific integrity to go through looking at all these trials and funding some of these things that took 10 years to enroll. And they stood by and helped support and provided that because this is where we have to go to help our patients. And I think the tricuspid story is still evolving. I think we started with mitral in the same way, and it's going to get more and more sophisticated, and we're going to find more and more patients that actually truly benefit and where those inflection points are in their care. But I do want to commend Abbott for their continued support of these really important registries and trials that actually meaningfully impact the way we do our care for our patients. So,
Any other comments?
No, I just want to, I agree, just to acknowledge Abbott for their enduring efforts to drive data, drive science. I think that the remaining, question that always comes up that people throw around, so is, are we going to repair or replace these valves moving forward? And I think this data is very compelling. And I think we're going to see something similar as we saw in the mitral space, where if you can repair the valve, you're probably going to be better off than replacing it, given all the downstream effects of having a valve in place, including pacemakers, anticoagulation, et cetera. So we've learned a lot. The data is highly supportive, and I think in the algorithm and the scheme of things, in the right patient population, repair is going to be the first kind of go-to therapy over replacement. That's my theory.
Does anybody, any questions from the audience? We do have microphones. We summarized it all. It's over.
All right.
All right. Thank you
everyone.
very much.
See you.